Hello, everyone. Good evening. I hope you're all doing well. Welcome to this lecture by Dr. Borgi as part of our surgical lecture series. My name is Asil Nahlawi. I am a final medical student at AUB, and I am part of the founding team of the Women's Surgery Interest Group and the Association of Women Surgeons, the AUB chapter. And I hold the position of treasurer on the team. Before I introduce our speaker for today, let me just remind you of a couple of instructions so that this session runs as smooth as possible. First, please make sure your microphones are turned off for the entire length of the session. Second, please write all your questions you have in mind in the chat box, and our speaker will be ready to answer them all at the end of the session. And third, and most importantly, don't forget to enjoy. So now I will start by introducing our speaker for today, and I'll be sharing before my okay. Yeah. So Dr. Jamil Borgi is an assistant professor of cardiothoracic surgery at the American University of Beirut Medical Center. He received his medical degree from AUB in 2004 and completed his general surgery residency at the Henry Ford Hospital Wayne State University program. He then completed his fellowship in cardiothoracic surgery at the University of Washington in Seattle. His work focuses on advanced cardiac surgery, including heart and lung transplantations, ventricular assist devices implantation, and mechanical circulatory support for end-stage heart and lung disease. He has a particular interest in aortic and mitral valve surgery for chronic thromboembolic disease and minimally invasive cardiothoracic surgery. He is board certified in both general surgery and cardiothoracic surgery. Today, he will be talking to us about aortic dissection, which is a crucial and very important topic for all aspiring surgeons. We are honored to have you with us, Dr. Burji. The floor is yours.
Good evening, everyone. Thank you for the introduction. I am pleased to be presenting here tonight online, and I'm impressed by the number of attendees. Apparently, everyone likes online learning. So I'll be talking about aortic dissection, specifically ascending aortic dissection, or what we call type A dissection, which falls under cardiothoracic surgery, versus the other type of dissection, which we will discuss briefly. And the goals of this presentation is to review the pathophysiology and presentation of type A dissection, second is to discuss the management algorithm and strategies, and highlight current literature about the topic. And I will finish my talk with some cases that we performed surgery on, to give you an insight about this disease and surgical management of it. So aortic dissection is a life-threatening vascular emergency. It does occur at the rate of almost 3% per 100,000 per patient year. To give you an insight, in Lebanon, if we assume that the population is around 4 million, then the numbers of expected aortic dissection should be in the range of 120 per year, which definitely we are not seeing, which gives you also an insight about the rate of misdiagnosis or patients who are not presenting for proper care. It is considered to be the most common aortic emergency. This graph shows you the increase in the rate of diagnosis, which falls under incidence over the years, starting in mid-80s into the mid or early 2000. And with that, the increase in the amount of surgeries performed on aortic dissection. Sir William Osler, the father of surgical training, was quoted to say, the tragedies of life are largely arterial. And to give you a historical perspective, King George II of England died in 1760 from an aortic dissection while he was straining on in a toilet. In 1819, René Laennec coined the term dissecting aneurysm, which really we don't like in surgery because dissections can happen without aneurysms, and aneurysms are definitely common without dissection. In 1954, DeBakey and Cooley performed the first surgical repair of acute aortic dissection. A refresher on anatomy. This is the aorta from the aortic root that you see here. This is called the aortic sinus, where the aortic valve lives, and from here the right and left coronary artery take off. This portion is called the tubular portion of the ascending aorta, and here is the arch where the brachiocephalic, left carotid, and left subclavian arteries take off, and then you have the descending aorta or thoracic descending aorta, which is composed of, from the thoracic aorta and then the abdominal aorta with their branches. So what happens when you have an aortic dissection? Once you have an aortic dissection, it really starts at an intimal tear, which is an opening in the intima that will let the blood go in between the intima and media, as you can see in this autopsy specimen. So this is blood sitting between the intima and media, which results in two lumens with proximal and distal propagation and multiple re-entry points, and you can see it in this CT view of a patient with type A dissection. Risk factors for dissection is definitely an aneurysmal aorta, which weakens the wall. So this is dilated aorta as a risk factor. Hypertension, which is logical. Someone with high blood pressure can result in a tear that will result in a dissection. Atherosclerosis, because it results in weakening of the wall, and multiple connective tissue diseases are considered high risk factors for aortic dissection, like Marfan disease, Ehlers-Danlos disease, and Louis Dietz. Also, inflammatory arthritis, bicuspid aortic valve, or true bicuspid aortic valve, which is a topic that we're not gonna dwell into because it is considered a risk factor because it's associated with aortic disease. Coarctation is also a risk factor. Iatrogenic, like trauma, can also iatrogenic, whether operative trauma or other types of trauma can result in dissection. So what are the classifications of dissection? You commonly hear about type A and type B, which is the Stanford classification, which is the more common classification. And type A, as you can see in this picture, is whenever you have a dissection involving the ascending component of the aorta. So this is A, this is A, and this is B. B is any dissection starting beyond the left subclavian artery. And type A can be, another type of classification is the DeBakey classification, which divides type A or Stanford type A into 1 and 2. And 1 is a dissection that starts in the ascending but goes all the way into the descending and sometimes all the way to the femoral arteries. And this indeed is the most common type of dissection. This is the second most common type, and type B is the less common type of dissection. Another form of classification is with regards to timing, and acute is anywhere between 0 to 2 weeks, even though I think this is this incorporates subacute in it. Chronic is beyond 2 weeks. Acute, really for us as surgeons, is anything in the first 48 hours of onset of symptoms. And what are the symptoms of aortic dissection? Most commonly, or in 85% of patients, it is acute tearing type or crushing type chest pain and sometimes back pain. It can be associated with shock secondary to tamponade, and we'll talk about that later. But shocky patients or patients can present with shock with low blood pressure, diaphoresis, secondary to low cardiac output, and that is the result of either tamponade, acute infarct from dissection into the coronaries, acute aortic regurgitation or free rupture of the aorta. It can present with syncope, and sometimes it presents with malperfusion syndromes. And like we said, the dissection will go into multiple branches and can result in MI if it goes into the coronaries, in strokes, and if it goes to the vessels of the brain. It can result in limb ischemia, spinal ischemia, or gut ischemia with sometimes GI bleeding. So we have to keep in mind, and for you who will go into other types of specialties, that symptoms may mimic other diseases, and missing the diagnosis is really catastrophic. Also, the presentation can be dynamic and variable depending on where the flap inside the aorta is sitting, and flow may come and go into a limb or an organ. So we should have a high index of suspicion when you have risk factors. And why do we need to properly diagnose this entity is because the mortality of it is very, very high. And here we're talking really about type A dissection. With type A dissection, so any dissection involving the ascending aorta, the mortality is quoted to be 1% per hour for the first 48 hours. So you have half of the patients will die within 2 days, and the other half will die within 1 month, or nearly 100% of the patient will die at 1 month if you don't intervene. Risk factors for mortality is definitely a higher age, more than 70. If the presentation comes with malperfusion to organs, if you have a tamponade and shock, acute renal failure, other forms of shock, neurologic deficit, which is malperfusion to the brain, and myocardial infarction. This is a classical study that was a number of years ago by the IRAD, or the International Registry of Acute Aortic Dissection. It looked at patients operated on for type A or type B, and it identified that when overall in hospitals that are under the IRAD, patients who received surgical treatment for type A dissection had a mortality of 26%, which is much better than the patients who did not receive treatment, only received medical treatment. This is in contrast to type B, where only 10% of patients who received medical treatment suffered from death or mortality. And this is why it was established that the treatment of type A dissection is surgical, whereas the treatment of type B dissection or dissection of the descending aorta is generally medical. So what is the management of patients with type A dissection? First of all, prompt diagnosis, because you don't want to lose time with an entity that is this urgent with this high of a mortality. And then you have the preoperative care. You have to refer the patient to the proper aortic center, or center where they perform surgery on aortic dissection, where surgical repair can be performed. And then you have the proper post-operative care and long-term follow-up. If we start with the diagnosis, again, as we said, the clinical presentation is generally that of a chest pain, sometimes with a pulse deficit, because the flap may take part of the branch to the right arm or left leg. So you'll have a blood pressure differential. You may have syncope from multiple reasons, most commonly tamponade. You may have murmur from a new aortic regurgitation, because the tear may distort the aortic valve, and then you'll have incompetent aortic valve and sudden onset aortic regurgitation. Or you may have a neurologic deficit, like an acute stroke from malperfusion to the brain. Patients may be hypertensive or hypotensive. It was noted in this study in 2003 that diagnosis is rarely immediate and might be misdiagnosed, or significantly delayed in up to 40% of the cases. What are the tests that you need to do when you suspect someone has aortic dissection, or someone is presenting with acute chest pain? Obviously, basic labs with troponins and D-dimers. I would also add lactate. Then you do an EKG and a chest X-ray, and signs on chest X-ray or hints that you have something like a dissection is left-sided effusion and a widened mediastinum. And then obviously CT scan is the gold standard, and it is most commonly performed or most common diagnostic tool for aortic dissection, and you will need contrast or IV contrast for diagnosis in order to see the two lumens. MRI is also tested with very high sensitivity, but we don't use it frequently because it's time consuming. Angiography is another modality, but it's also time consuming, and TTE or transthoracic echocardiogram versus this should be TEE, transesophageal echocardiogram. So all of these modalities are very sensitive, and like I said, MRI even has higher sensitivities than CT, but less commonly used because it is time consuming. So the test of choice, I would say, is CT of chest with IV contrast or CT angiogram. So you diagnose someone with aortic dissection, what would be the next step? The next step is proper preoperative management, which will include neurological checking and documentation, because you want to know that whether the patient comes in or came in with a stroke, or whether the stroke developed after surgery or after a while. Also, you have to document your pulse exam, right arm, left arm, carotids, femorals, and distal lower extremities. You have to establish arterial lines, preferably one line on either side. And most importantly is to obtain proper blood pressure and heart rate control, or what we call impulse control. So you have to keep a heart rate below between 60 and 80 ideally, and a blood pressure with a systolic below 120, 110 ideally. And for that, you use as first line beta blockers and as a second line calcium channel blockers. Pain management is important because this entity is very painful. And then obviously you activate or you alert the surgeon and activate the operating room, or transfer to a place where they can perform this surgery. Now come into the stage of surgical management. So we take the patient to the operating room. Why do we operate on patients with the type A dissection? So the rationale for surgery is to prevent death, obviously, because it's a highly mortal entity. And death in aortic dissection occurs from re-rupture, which is the less common form of death, tamponade, which is a common form of death. Tamponade happens because you have weeping of fluid and blood from the dissecting area into the pericardial sac. Heart failure, acute heart failure, which can result from either acute aortic regurgitation or from acute myocardial infarction. Surgery is reported to have a perioperative or in-hospital mortality of 26% in the international or the IRAD registry. But truly in experienced centers, this mortality should be in the range of 10%. And this is, to me, what is considered acceptable, and even less than that. Some reports are based on followed patients for 5 years or 10 years, and they showed a survival ranging from 37 to 71%. Just to give an idea that these patients are usually sick patients, and they have other comorbidities and may not have a very long survival, even if you get them through the operation. There's no randomized controlled trial that compares medical treatment to surgical treatment in acute type A dissection, but generally it is a general consensus that once you perform surgery for type A dissection, you convert a 90% or higher mortality risk to a 70% or higher survival chance. So this is the right therapy for it. Just a few details about the surgery that we perform and the goals of it. So the goal is to replace the portion which is the ascending aorta, which is the area that is the source of all evil in this entity. and you replace it with a graft. Also, you have to restore the aortic valve competence in case the aortic valve is distorted with the dissection. You have to eliminate the tears in that region. Basically, when you resect and replace with the graft, you do this elimination. And you have to try to restore flow into the true lumen and avoid flow into the false lumen. And this last one, which is persistent false lumen, or false lumen can persist after surgery. And this is something that sometimes we have to deal with at a later stage. Just a few pictures about what we do in surgery. This is a graft sewn to the right axillary artery, which is the way we commonly, or I commonly, put the patients in this with this diagnosis on cardiopulmonary bypass, because you cannot access the aorta because it's a ruptured or a dissected aorta. This is a dissected aorta, even though we've seen worse than that, but this is an aneurysm that is dissected. So this is how it looks from the outside. This is after resection of the aorta or the aneurysm that is dissected. So this is one end, and this is the other end. What you see here is the aortic valve, and here it appears to be competent. And this is the area that is replaced with a graft from here to here. And there are multiple ways to do this operation depending on really on where the tear is. So if you remember the anatomy that I described earlier, this would be the aortic root, and this is the ascending aorta. And this type of surgery is just, which is the most common, is changing the aorta from the sinotubular junction, or from this area between the sinuses and the tubular portion, until the beginning of the arch. This is almost the same, but with a hemi-arch. So you remove, or you change all the undersurface of the arch here. The rest of these are total arch. So this is a total arch replacement. This is a partial arch replacement. And this is a total arch with an elephant trunk, which is beyond the scope of this lecture. Here, this portion, this image here is when you replace the ascending aorta, but also replace the root and reimplant the coronaries. And this is something that we have to do often, and it's called the Bentall procedure. And we do that specifically when the tear is at the level of the root. So you cannot leave a tear with a root. And sometimes we have to replace the aortic valve, and we use a valve conduit. So this is a valve that introduced or built into a graft. And this is the final product when you put that part here at the level of the aortic root and reimplant the two coronary arteries. So as far as patient selection and which patients to operate on, you have to stratify the risk, or the patient into low, high, or medium risk. And we know that the higher the age, the higher the mortality. Whether the patient had a previous operation on their aortic valve is also a risk factor. If they present with shock and hypotension, definitely is a risk factor for death. Preoperative tamponade and evidence of malperfusion. And sometimes patients or centers will consider a patient who is comatose or presenting in a pre-death situation as a very high risk patient, and they will turn him down for surgery, and they will just let them die. And some people will think twice about operating on someone in their 80s because of the high death rate. But I have to say that many times we do operate on 80-year-old patients, and they do very well. So the timing of surgery, as I said, this is a surgical emergency, and generally whenever you hear about aortic dissection, type A dissection, you have to rush the patient to the operating room, particularly if they are presenting within the first 48 hours, because this is the time of highest chance of death. Sometimes you see a patient who are beyond 2 days, and these patients can be scheduled to surgery in a more relaxed way, so in an urgent way, not an emergent way. Obviously, does not apply for someone who's in shock and who has tamponade of heart failure or malperfusion. Malperfusion, whether we're talking about limb malperfusion, heart malperfusion, or brain malperfusion, is definitely associated with worse outcomes, and it is something that happens at an incidence of 16 to 30%. Coronary malperfusion will present with signs and symptoms of a heart attack or a myocardial infarction. It does happen at 10 to 15% of patients with aortic dissection. It has a higher mortality. It increases the rate of aortic root replacement, obviously, because that means that that part of the heart is involved. It requires bypass to one or two of the coronaries at the time of repair. And I have to say that it does happen. I've seen that frequently when patients present with aortic dissection associated with coronary malperfusion, and people think that they are having a acute coronary syndrome, and they load them with antiplatelets, and then once the diagnosis of dissection is made, we have to go and operate on someone who's just received a huge dose of Brilinta or Plavix. That's not usually a very good situation. Brain malperfusion is another form of malperfusion, and it is associated with obvious post-operative prognosis. But some patients with just a little bit of global neurologic dysfunction have a similar outcome, and more than 50% will gain full neurological function if you operate them promptly. So speed, cannulation, and perfusion strategies are critical in improving neurological outcome. Spine malperfusion is a rare entity. I've seen it twice, and it results in paraplegia. And I'll show you a case in the end that is related to spine malperfusion. Limb malperfusion is pretty common, and it occurs in apparently 12% only, but I've seen it frequently. Diagnostic delay because the presenting symptom may be just pain in the leg and a lost pulse, and people think this is an acute limb ischemia that they have to deal with. So always keep a high index of suspicion for aortic dissection. Gut malperfusion is one of the worst type of malperfusion. It's associated with high mortality. And some people advocate first treating the malperfusion of the abdominal compartment with endovascular approaches before treating the actual aortic dissection. And surgical opinion is divided about that. We don't see it frequently, luckily. So for the sake of time, I will not discuss surgical approaches, and this is probably beyond the level of this presentation. But multiple strategies do exist, but generally the principles are to put the patient on cardiopulmonary bypass through a peripheral cannulation modality. I prefer the axillary cannulation. So we put the patient on heart and lung machine, and then we open the chest. We cool the patient down so we can stop the circulation completely, and we replace the ascending aorta definitely. And sometimes we have to replace the root and do reimplantation of the coronaries and change the valve. And sometimes we have to replace the arch and do reimplantation of the brain vessels. And sometimes we have to do both at the same time. So I'll skip that technical component. And I'll show you here just this image about something that is becoming more fashionable these days is to, when you treat is to leave an endograft in the descending component so you can avoid what we call a persistent false lumen. So you fix the ascending component and leave a stent in the descending component. And I'll show you a few cases just to highlight what we discussed. The first one is a 55-year-old male who presented with chest pain with a history of hypertension and was known to be to suffer from a high blood pressure and had a history of a type B dissection, so a dissection that started from beyond the left subclavian, and that dissection was treated with an endograft or a stent that you can see in the lower image here. And that was actually the cause of his ascending type A dissection, and I've seen it a few times. And why I would say that, because it's a dissection that starts from the spikes of the end here that will poke into the aorta and result in an intimal tear. So I treated him by performing an axillary cannulation and changing the ascending graft. So from here, the ascending aorta from here to here, replaced it with a 28 millimeter Dacron graft under circulatory arrest and antegrade cerebral perfusion. He was discharged home after 19 days because he suffered from pneumonia and some other problems that resolved. The second case is another 50-year-old that presented to another hospital. That was back when I was in the States. Presented with chest pain and left arm weakness. He also had right upper extremity diminished pulse. And the CT showed a type A dissection, but if you look at it here, you'll see that the dissection is going into the innominate artery. So he had low flow into the innominate artery that resulted in low flow into his right brain, hence the left arm weakness. And at the same time, he had a gone pulse in the right arm from the dissection. Again, the operation was almost the same, and he was discharged home on post-operative day 11, and the arm weakness resolved after surgery. This third case is a 75-year-old female who presented 12 hours after the onset of lower extremity pain and paraplegia. She had multiple comorbidities, and her CT, like you see here, is obvious dissection. This is a sagittal view showing the dissection in the arch going into the descending aorta. This is the dissection on a coronal view showing the dissection in the ascending aorta. As you can see, she has a enlarged aorta altogether. And on this image here, you see how much junk she has in her abdominal aorta with severe atherosclerosis. So this patient presented in a much worse situation. I had to do bilateral femoral cannulation and right axillary cannulation so I can resume flow to her lower body, because she had interruption of flow. And like you see here, there is no flow beyond the abdominal aorta. Did an ascending and partial arch replacement, bilateral 4-quadrant fasciotomies in her legs. Her post-operative course was complicated by myoglobinuria from muscle death and acute renal failure. She expired on day 4, so we don't always have an excellent outcome. Case number 4 is a 61-year-old male transferred from another hospital where he presented with chest pain and paraplegia. So he wasn't able to move both his legs. He had palpable pulse in his femoral arteries, so it was not a situation of flow that causes paraplegia. So as you can see here, there is flow only in the false lumen. And so this is the ascending aorta here with flow here in the false lumen. This is the the descending aorta with flow here. And as you can see, the posterior portion of the descending aorta, where branches to the spine take off, they don't have any blood flow. And this is why he had ischemia to the spine, resulting in paraplegia. And here, reconstitution of both iliac arteries. So he had actually perfusion to the legs, but a neurological malperfusion. This is, again, the operation was almost the same, but I had to do a bental, so I replaced his root. As you can see here, this is the aortic root with the ring of the mechanical valve that I implanted. This is the ascending aorta replaced. And here you can see flow in both the true and false lumen, which is acceptable if you get that. And of note that the patient had return of his function of his legs and was discharged walking on day 9. This is another case, a female that presented with chest pain, with an obvious aortic dissection, and you can see it's a type A with DPK type 1 with dissection going into the descending aorta as well. And at the hemi-arch with aortic valve resuspension and also reimplantation of the innominate artery, and she did well. And this final case is a 27-year-old male, so this can happen in younger patients as well, who presented with sudden chest pain that happened after or during intercourse. He had a history of hypertension since the age of 22, and that should raise a red flag. So I did a hemi-arch with aortic valve resuspension. He was fine in the end. This is the CT post-operatively showing the repair. And of note that also on his CT, we noticed this, and that may give you a hint to the diagnosis of why he had hypertension. So this patient had an undiagnosed coarctation, so he had hypertension in the proximal portion of his aorta. That was later fixed with an endovascular dilation and stenting. And with that, I will end my presentation. If you have any questions, I'll be happy to answer them. Thank you.
Thank you so much, Dr. Borgi, for this very informative lecture. So guys, if any of you have any question, please write it down in the chat box, or you can unmute yourself, and we can, Dr. Borgi can answer it now.
How does blood pressure change in patients with aortic grafts since it has the baroreceptors? That's a good question. It does not change. So baroreceptors are obviously present in the on all of the vasculature, and I don't believe I remember very well how the control happens, but it definitely does not happen at the level of the ascending aorta, so it does not change. And very frequently we exchange a portion of the aorta, whether ascending or descending, with a graft, and patients do very, very well with that. And this has interestingly started in the 1960s. So this is the same type of Dacron graft that is still used. We still use it till now, and it has shown excellent results. Okay, can TVAR be performed for type A dissection instead of open repair? The complexity of the ascending aorta, because of the root, the aortic valve, the two coronaries coming off the root, and then the branches to the brain, will make TVAR very difficult. And until now, it's only investigational. Maybe one day it will happen. But till now, as I said, the treatment of ascending aortic dissection is open repair versus endovascular repair for the descending. Okay, can you explain the principle of femoral and axillary cannulation when there is low perfusion? I mean, what are you injecting in it? Okay, so the principles of cardiopulmonary bypass is that you drain the blood from the venous system, specifically from the right atrium, through a large cannula, and then you put back the blood back into the aortic system. And generally, in regular cardiac surgery, we do that by cannulating the ascending aorta directly. But in this situation, you cannot cannulate the ascending aorta because it's dissected or near rupture. So we go and cannulate peripherally. So you deliver all the blood that you drain, which is almost 5 liters or the full cardiac output per minute, and you deliver it into the peripheral system. In this situation, axillary cannulation or femoral cannulation. And you can do your surgery, whether it takes 6 hours or 10 hours on that configuration. So you restore blood flow. Do we give post-op anticoagulation? No need unless you put a mechanical valve instead of the normal valve if you replace the root. But for the graft, you don't need anticoagulation. Some people will give aspirin for a short period of time. How does blood reach other sites in axillary cannulation? It's a continuous tube, so you can put blood here, and then you will get blood into the whole system, even into the coronaries, because you have a competent aortic valve. It's hard to imagine that, but it does happen. Maybe you should see a cardiac surgery one day, and you'll understand that principle. I think that will be it. Thank you very much.